And this is one reason that many practitioners are using DOACs for treating cerebral venous sinus thrombosis, though there is not much of evidence available for it. So we thought that we should select an article which is appropriate, and we should discuss out the evidence that is available in literature. So Dr. Dulari Gupta will be discussing the article, and chairpersons will be Dr. Sunil Narayan, also Dr. Rajeshwari. Following that, we started introducing a segment on EBM. Dr. Ila will be talking on the biases that are present in the retrospective studies, because this article is a retrospective study. Also, I'll be telling briefly about confidence intervals. So before we start and hand over to Sunil Narayan, I welcome our President of Indian Academy of Neurology, Dr. Nirmal Surya. Dr. Nirmal, would you like to say a few words before the chairman takes over the proceedings?
Sure, Shankar Prahas Gurti. Thank you very much for initiating this active journal club through the stroke subsection. Stroke subsection has always been a very active subsection of Indian Academy of Neurology. Earlier, Dr. Kameshwar Prasad, along with Sunil Narayan, has been very active. And now, with Sunil, you have joined, and you have started a different initiative. I'm sure this will be infectious, and many other subsections will start doing this journal club, which is, in fact, is a good practice. We will promote this so that many of these postgraduates can also attend and be part of the discussion with the experts who all are here. I wish you all the best, and I'm looking forward to your further activities. I know that summer midterm stroke school and meeting, and I'm sure these sort of activities are definitely going to improve the knowledge of everybody, including the practitioners who are practicing. My best wishes to all of you. Please continue doing this and send a short report to the Secretary IEN so that can be posted on the website in your subsection page. Thank you very much.
Thank you, Dr. Nirmal. Thank you, Dr. Nirmal, very much. And we intend to do on every month, first Monday, except next month we are having the annual midterm conference. So Dr. Sunil will tell more about the midterm conference in his introduction. Dr. Sunil, you can take over along with Dr. Rajeshwari to conduct the proceedings.
Sunil Narayan sir has got logged out. I'll just reach out to him.
Yeah. I think Dr. Rajeshwari, you start, because Sunil is locked out. We should not waste any more time. Okay, he will join us. He will join us in the discussion.
He will join, but you can begin with the program.
I think sir has already given a very good background to the reason why this article was chosen, and it was a very interesting read for me. I welcome now Dr. Dulari Gupta to share her slides, and so we can have a good discussion about what this study actually means for our practice. With that, I hand it over to Dr. Dulari.
Good evening, everyone. Can you see my slides?
Yeah.
Yes.
And am I audible?
Slightly louder.
Is that better? Am I audible?
Yes. Yes.
Sure. So I'd like to, should I start now or should we wait?
No,
Any-
please start.
So on the onset, I'd like to thank the organizers, especially Gurthi sir, for giving me the opportunity to present this journal club. The topic we'll be discussing today is direct oral anticoagulants versus warfarin in the treatment of CVT, which is the Action CVT, a multi-center international study. So this study addresses a very important issue that we face in clinical practice. Many clinicians are already using DOAC to treat CVT. And this is an observational study which has documented these real world findings. So in 2017, when the European Stroke Organization guidelines for CVT were published, the question of DOAC was also addressed and whether they are safe to treat CVT. But they deemed that the quality of evidence was judged to be very low based on because all studies were observational studies with a very high risk of bias. So they did not recommend the use of DOAC, either factor A or thrombin inhibitors for the treatment of CVT. Following this, the RESPECT CVT study was published, a landmark study in CVT. And this was an exploratory, randomized, parallel group, multi-center, blinded study, which took 120 subjects. 60 were treated with dabigatran, 60 were treated with warfarin, and were followed up for 24 weeks. None of the subjects had any recurrent venous thromboembolism. One had a major bleeding event in the dabigatran group. Two had intracranial bleeding in the warfarin group. And one had a clinically relevant non-major bleeding in the warfarin group. So this was their study summarized in a nutshell. First 5 to 15 days, people were treated with parenteral unfractionated heparin or low molecular weight heparin and recruited into the study. After which they were randomized into a 1:1 basis, either into the dabigatran group, 150 mg BD, or warfarin with the dose adjusted to an INR for 2 to 3 weeks. They were treated for 24 weeks or 6 months, which is the duration that we normally treat CVT without any underlying procoagulant cause. And another follow-up was done 7 days after the end of treatment. So in this trial, they found that both treatment arms had very low risk of recurrent venous thromboembolism, and risk of bleeding was similar with both medications. And they suggested that both dabigatran and warfarin may be safe and effective in preventing recurrent venous thromboembolisms in CVT. But because of limited sample size, the non-inferiority or superiority of either treatment arm was not demonstrated. This brings us to the next major study, which is the study we'll be discussing today, Action CVT, a multi-center international study. This was conducted by Shahidi Yagdi et al. And it has been published in March 2022 in the Stroke Journal. So I'll go over the visual abstract of this study, which kind of sums up the study in a slide. This is a multi-centric international retrospective study. 125 patients with CVT were recruited. No, they were recruited, and whether it was documented whether they were treated with DOAC or warfarin. And they found that similar recurrent venous thrombosis risks were present in either group, similar death risk, similar partial or complete recanalization rates, but the DOAC group had lower major risk of hemorrhage, and this was statistically significant. So I'll go on to the main study. CVT is an uncommon cause of stroke, and DOAC are a viable and preferred alternative to warfarin for the treatment of patients with venous thromboembolism. But limited data exists about their safety and efficacy of DOAC in the treatment of CVT. Due to the rare occurrence of CVT, conducting large randomized controlled trials is difficult and expensive. So this study attempts to find the safety and efficacy of DOAC versus warfarin in CVT in an observational real-world setting. In the methodology, this is a multi-center study. 27 centers were recruited from the US, Italy, Switzerland, and New Zealand. It was a retrospective observational study from Jan 2015 to December 2020. All patients with CVT at each institute were identified using the ICD-9 and 10 coding for CVT. Patients were excluded if they were not treated with oral anticoagulants or if they required any specific anticoagulant strategy. If they had antiphospholipid antibodies, then warfarin was the drug of choice. If they had any active cancer, then DOAC were preferred. And in pregnancy, warfarin was contraindicated. When they were doing the recanalization analysis, they excluded patients who had undergone endovascular treatment or those who were taking both drugs together. So study outcomes, the primary outcome was looking at recurrence of venous thromboembolisms. So both venous thromboembolism and CVT during the follow-up period. Imaging outcomes, they looked at recanalization status at the last venous imaging study that was recorded and divided into ones who had no recanalization, those had partial recanalization, and those with complete recanalization. Safety outcomes, they looked at major hemorrhage, that is new or worsening intracranial hemorrhage, or any major extracranial hemorrhage, defined as a systemic hemorrhage with at least 2 grams drop in hemoglobin or anyone who required a blood transfusion. Any deaths were also recorded. The statistical analysis that they used, first they did a univariate analysis and the patients were divided into two groups, those who got strictly warfarin and those who got strictly DOAC. Then they did an unweighted and inverse probability of treatment weighted, unadjusted and adjusted Cox regression analysis. The patients who switched oral anticoagulant types were considered as crossovers and analyzed using a as treated approach. Fully adjusted models also included specified variables and also variables which were significantly different between the two baseline groups at baseline. I'll say a few words about the inverse probability of treatment weighted analysis, which was something which was new for me. And this is one of the important kind of statistical analysis that they've used in this study. So normally in a randomized control trial, we take, there's a 1:1 division of patients who go into the treatment arm and the control arm. Whereas in an observation study, this is not always in our control. And we cannot predict how many patients would be in either the treatment or the control arm. So this kind of statistical analysis is used to infer data which we normally get from a randomized control trial through an observational study. So it's kind of used to elevate an observational study to the level of a randomized control trial. So suppose there's a single binary confounder variable x, and if among people with x equal to 1, there's only 10% chance that these people will receive the treatment or be in the treatment arm. So their propensity score or the chance of getting the treatment would be 0.1. So we'll divide those in the treated arm and those in the control. So the chance of being in the treatment arm is 0.1 and those being in the control arm would be 0.9. So one person, if you have to compare them like we do in a randomized control trial, we'll usually take 1:1. So one person in the treatment arm would count the same as 9 people in the control arm. Now, usually if we match, like we do in many randomized control trials, match for age, sex, or risk factors, we would be choosing the one in the control arm, which is similar to the one in the treatment arm. But the data of the other 8 patients in the control arm would be lost in the analysis. So to prevent this, rather than match, we could use all the data in both the treated and control arm, but downweigh some and upweigh the others. That means that this one patient would weigh 9 times more in the treated arm than any of the patients in the control arm. This is accomplished by weighting by the inverse of the probability of treatment received. So what is the chance of a person who is in this study receiving a treatment? It is 0.1. So the inverse of that is 1 by 0.1 or 10. So this is what you get into the treatment arm. Whereas in the control arm, what is the probability of them being in the control arm? It is 0.9. So 1 divided by 0.9, which is 10 by 9 or 1.1. So each patient in the treatment arm gets a weightage of 10, whereas each patient or subject in the control arm is given a weight of 1.1. And if you add all the controls, that will equal to the one person in the treatment arm. I hope I have tried to explain this inverse probability of treatment weighted and how they give different weightage to people in the treatment and control arm to try to get them to equalize as a one-to-one thing which we have in a randomized control trial. I'll get back to the study. So in the results of the study, a total of 125 patients with CVT from 27 sites were recruited, out of which 845 met the inclusion criteria. The mean age was 44.8 years. Women were were more affected, 64.7%. Those who were strictly receiving DOAC were 33%, whereas those receiving strictly warfarin were 51.8%. As you can see in this, the numbers are not equally matched. We are comparing those with on DOAC and warfarin, and they're almost twice the number of patients on warfarin. And those who received both were constituted about 15%. So this is the study flow chart. Out of 125 patients, those were excluded who had any underlying cancer or antiphospholipid syndrome or who didn't receive oral anticoagulation. 845 patients took oral anticoagulation, 279 were on DOAC, 433 were on warfarin, and 128 received both DOAC and warfarin. Out of the 845 patients, only 525 were taken for the recanalization rate analysis because many did not have a repeat imaging. Some underwent endovascular treatment and some were receiving both drugs. Comparing the baseline characteristics between those patients who were on DOAC versus those on warfarin, age, race, demographics, and etiology were pretty much similar in both categories, apart from the fact that patients on DOAC were almost 2 to 3 times more likely to have a past history of venous thromboembolism. Other clinical features and imaging characteristics were also similar, but those who were on warfarin were twice more likely to have one or more antiphospholipid antibody positive, and those on warfarin had twice the chance of being treated with low molecular weight heparin. The median follow-up in both groups was 345 days. Rate of recurrent venous thrombosis was 5.6 per 100 patient years. This included 17 venous thromboembolisms, 27 recurrent CVTs, which included both extension of the previous CVT as well as de novo new venous thrombosis, which has occurred in the brain. 2 had both venous and CVT. Major hemorrhage was seen in 3.77 per 100 patient years. 23 had intracranial hemorrhage and 9 had extracranial hemorrhage. Deaths were recorded in 1.8 per 100 patient years. Recanalization analysis was done among 525 patients. As I mentioned, not all patients were included in this. 36% had complete recanalization, 48% had partial recanalization, and 15% had no evidence of recanalization at all. They did a Kaplan-Meier survival analysis, and they found that the rate of recurrent venous thrombosis was 5.26 per 100 patient years in the DOAC group, this is in red, versus 5.87 per 100 patient years in the warfarin group. So DOAC fared better. Also, major hemorrhage was only 2.44 per 100 patient years in the DOAC group, which was almost half of that in the warfarin group, which was 4.7 per 100 patient years. This was not statistically significant initially, but when they used the inverse probability of treatment weighted analysis, then it was found to be statistically significant. Also, when they adjusted for pre-specified variables or checked variables which were different between the two groups, this was found to be statistically significant. The third survival analysis which they did was death during the follow-up, which occurred more commonly in the warfarin group, 1.9 per 100 patient years, compared to the DOAC group, which was 1.8 per 100 patient years. So the rates of recanalization, they clubbed both complete and partial recanalization, which was around 86% in the DOAC group versus 84% in the warfarin group, not statistically significant. So they did a propensity score matching, and DOAC treatment was associated with similar risk of recurrent venous thromboembolism, also death, complete or partial recanalization with no significant lower risk of major hemorrhage, comparing both the groups. As you can see, they have first looked at the same parameters: recurrent venous thrombosis, major hemorrhage, death, and partial or complete recanalization. In the results are quite same with the unadjusted, weighted unadjusted, or when they have gone through different models or of it. The only thing which has changed is in this major hemorrhage. Initially, there was no significance between the two groups, but when they went to the weighted or the adjusted models, they found it to be statistically significant. So they did a sensitivity analysis. In this sensitivity analysis, they usually all the parameters that you have analyzed in the univariate analysis, they will keep changing or adding or subtracting one of these if to see if whether that makes a significant difference between the two groups. So deep vein involvement, which can cause more altered sensorium, and a baseline hemorrhage were excluded because these are not well-known predictors of recanalization or any major hemorrhage. Presence of greater than one antiphospholipid antibody, that was excluded. Then those who had been event-free of the outcome of interest but were lost to follow-up before the 90 days follow-up were excluded. This study was conducted during the COVID pandemic, and there were 6 patients who had CVT associated with COVID-19, and they were also excluded to see whether it makes any great difference. But despite all these different things being excluded and reanalyzing, they found that the results remained unchanged. Going on to the discussion, this real-world cohort of CVT patients, DOAC treatment was associated with a similar risk of venous thromboembolism recurrence, death, and CVT recanalizations rates, but with a significantly lower risk of major hemorrhage compared with warfarin. In contrast to previous studies, there was a risk of major, in which hemorrhage was more with DOAC. This study showed less chance of hemorrhage with DOAC. And this similar kind of favorable safety profile has been observed in DOAC over warfarin in other non-CVT patients, like venous thromboembolism and non-valvular atrial fibrillation. Although DOAC do not require blood level monitoring, they are generally more expensive than warfarin, and a cost analysis comparing DOAC to warfarin and CVT is required. So these are the limitations of the study as stated in the study itself. This was a retrospective observational study, and thus it's possible that there's a residual treatment by indication bias. About 15.7% of patients were lost to follow-up within 90 days, which is actually within the acceptable rate of 20%. There's a low event rate of recurrent venous thromboembolism, so this is under par to show any great difference between the two groups. Recurrent CVT included both de novo CVT as well as CVT extension, and this may explain some of the higher rates of CVT recurrence that has been recorded. Data of INR levels in warfarin treated patients was missing. So the recurrent venous thromboembolism or the major hemorrhage might have been because of sub or supratherapeutic anticoagulation, because we are not exactly sure how long the patients were in the adequately coagulated state. Rate of asymptomatic hemorrhage was low because of an ascertainment bias, because there was no, this is a retrospective study, patients weren't routinely screened at certain time intervals to see if there was any new hemorrhage. So if the patient never complained of headache or was not evaluated for that, we would not pick up asymptomatic hemorrhages in the study. And also the timing of follow-up imaging was heterogeneous and varied between different patients in different centers. So this is a brief commentary about the study. Using the intention to treat weighted analysis, they have tried to replicate the results of a randomized controlled trial in an observational study. Thus, despite very promising results, we need to remember that it is essentially an observational study and also a retrospective observational study. So no attempts have been made to reduce biases which are inherent in an observational study. Also, observational studies are very important and are the basis of hypothesis generation. But recommendations from these are always so stronger when they're supported by more robust evidence, which we would take, say, a randomized controlled trial. So more robust data which is generated from a randomized controlled trial is still required to establish the safety of DOAC in CVT and to enable us to confidently use them. Just some more comments on the study. Was the patient population clearly defined? It's a retrospective chart review of CVT, and cases have been selected depending on the ICD coding from all the participating hospitals during a pre-specified study period. Since the centers were mainly located in North America, Europe, and New Zealand, this is not a global representation. And large parts of the world, especially Asia and Africa, where CVT is much more common than in the Western Hemisphere, have been totally excluded. Is there a common point in the course of the disease in which patients were recruited? No. They have not specified it, and because it's a retrospective analysis, it's unlikely that all patients were sought at the same point in their disease course. What are the important prognostic factors that they have looked at and ascertained for? They have not, because this has been a retrospective study. Is the follow-up sufficiently long and complete? I would say yes, because the mean duration of follow-up was around 345 days, which is much more than 6 months. Usually in patients with CVT without any non-modifiable risk factors, we give anticoagulation for 6 months, and this duration was covered. Also, the loss to follow-up was only about 15.7%, which is well below the cutoff level of 20%, which we are allowed to give a leverage for. Was there any assessment of outcome, objective outcome criteria? Now, the primary outcomes that they've looked for are recurrent venous thromboembolism, major hemorrhage, and death. Now, they have not specified if these outcomes were blinded, but recurrent venous thromboembolism and major hemorrhage and intracranial hemorrhage, these are radiological outcomes, and they could have been easily blinded, but it has not been mentioned in the study. It's left to the reader's discretion to think whether they were blinded or not. So the absolute risk when we compare between those of recurrent venous thromboembolism, it was higher in the warfarin group, 5.87 compared to 5.26 per 100 patient years. Major hemorrhage was almost double in the warfarin group, 4.7 per 100 patient years compared to 2.44 in the dabigatran group, in the DOAC group. Also, deaths were more in the warfarin group, 1.91 compared to 1.81 per 100 patient years. They have given survival analysis through the Kaplan-Meier survival estimates for recurrent venous thrombosis, major hemorrhage, and death. What was the mean survival time? The mean follow-up time was around 345 days, which extends further than the normal time that we treat patients with CVT for. How precise are the prognostic estimates? So when you look at the confidence intervals, it's important to see whether they cross zero and whether they can be both negative or positive. And in all the three primary outcomes that they have studied, recurrent venous thromboembolism, major hemorrhage, and death, the confidence intervals seem to be relatively narrow and they do not cross the 0 point. So I think they are valid. Can our patients compare to the patients in the study? Now, they do have, it's a young age group that they have studied, which is similar in India also. It's a younger population who are more likely to have CVT. But they've concentrated on the Western world and New Zealand. So it is not a globally representative sample size. Normally in India, we see a lot of male predominance of CVT, whereas they had more females. And I do feel the risk factors that we see are much more different, with alcohol being one of the most, alcohol postpartum being much more common in developing worlds than what they have shown. Does this study increase our understanding of the disease? Yes, I feel it definitely does. And it hints towards the safety of DOAC in CVT. And this is also supported by similar results in usage of DOAC in venous thromboembolism and non-valvular atrial fibrillation. Should we reassure or counsel our patients? Not yet. Since this is an observational study, the results should be interpreted with caution. And I feel we should wait for the ongoing randomized controlled trials of DOAC and CVT before completely changing clinical practice. So these are the trials which are ongoing: the DOAC CVT trial and the SECRET trial, which is study of rivaroxaban for cortical venous thrombosis. Thank you.
Thank you, Dr. Dulari. That was a very good presentation of interesting work. You have given a good introduction right from how to justify this patient control ratios, the importance of repository analysis, sample size determination, and the various and of course you touched down on the sensitivity analysis, where one could look at various factors which could various subtypes of CVT, how that they could have influenced the outcome from the generalization of the CVT results, and also describe the limitations very exhaustively, and showed the limitations. So the once you put the commentary was the ones that are your own critical analysis. Am I right? The what you showed as the commentary,
yes sir.
They are your own critical analysis, yes. Correct? Right. Okay. So I just wanted to, before I hand over the further discussions from Dr. Rajesh, the co-chair, and also from the all other participants, I just wanted to ask you, the baseline slide. Can you just put up the baseline slide? There were 2-3 parameters which were not really matching. Just wanted to ask you to what extent they would have, what kind of contribution they would have had in the comparison between the two.
Yes, so they were when there were basically 3 things that were different between the two groups. Yes. One was the ones who had past history of venous thromboembolism. It was much more common, almost 2 times more common in the DOAC group. Whereas,
but you didn't find any significant difference in the between the two groups.
So the rest of the parameters.
This is also an outcome event, isn't it?
Yes. So, but the other was the amount, the ones who had anti-lipid antibodies and the usage of low molecular weight heparin. The thing is, because these were significantly different between the two groups, in one of the sensitivity and in all of the major outcomes, they have analyzed with some pre-specified variables like age, sex, and also with groups with outcomes which with factors that were different between the two groups. So each of the analysis they have done comparing like taking these into account also, and they've still not found any great difference. So because these were almost double, there was a significant difference between these two groups. So these 3 parameters in each of the outcomes, recurrent venous thromboembolism, death, and major hemorrhage, they have tried to account for those in the analysis.
Right. So despite the fact that VT was higher in the, can you just go back to a particular slide again?
Yeah.
The same slide which you are showing.
Yes,
just for 1 minute. Yeah. So despite the fact that it was higher in the DOAC group, once you actually put them in onto DOAC and continued for, say, a mean follow 6 months, I think you had given average exposure was how long?
So average was around, so average was 6 months, but the follow-up was 345 days, almost 1 year.
So you didn't find any significant difference between the recurrent embolism between these two groups.
In fact, it was lower.
So which means that despite having a higher
baseline risk,
yes, the fact that the same results were achieved, that actually, even though there is no significant difference between the two groups, it could suggest in favor of the direct inhibitors, isn't it?
Yes.
So, could you do some kind of a adjustment for that fact?
So if I can just show you this, which I've got for the risk factor of major hemorrhage. So first they have just done the unadjusted Cox regression analysis, and they've not found the p-value is 0.06, so it's not significant.
That's
but
for the
when
hemorrhage.
Yes, but then they've used the inverse probability of treatment weighted analysis, and the p-value is more significant. Also, each of these parameters, they have adjusted for some pre-specified variables and variables which are different between the two groups. So these three variables that we saw highlighted in yellow, they have adjusted for these, and in that model, which is what is shown in the second model for pre-specified weighted model 2. And there is, this is definitely in major hemorrhage, all the ones have been found to be significant, and even the unadjusted one, it was tending towards 0.05 we take as significant, it was 0.06. And when they did the other modeling, it came out to be significant. But the rest did not change.
Okay, so the significant difference was found for the major hemorrhage when you made this adjustment.
Yes.
But not for the other factors.
No, the others, the results remained pretty much similar.
Yes, that's interesting. Yes. So what's the kind of, what will be the strength of evidence of we know that there are different sets of evidences for different kinds of studies, starting from good meta-analysis and high quality random RCT, and also where would you put the evidence from this study?
I don't exactly remember the classification, but weak, like
observational study.
Yeah, it is an observational study.
Yes.
So I would put it as weak.
Okay, we'll probably come back to that, but I will allow the others to
definitely
continue the discussions. Dr. Rajeshwari, would you like to?
Yes, sir. Dr. Dulari, thank you for that wonderful presentation. Could you just take us back through that survival analysis for death? Like what I see is that while the final analysis on the hazards ratio seems to be that there's no difference in death between DOAC and warfarin, the survival analysis, especially in the middle part, seems to show a difference between the two groups. Are there any comments, or have they attempted to look at these things or discussed any of these? And what are your thoughts on that?
1 minute. I'm not able to share my screen. Just 1 second.
What happened? Digital team, could you help with that?
Can you hear me?
Yeah.
Yeah, we can hear you.
Okay.
Yes, ma'am.
So is it okay if I just speak? Ma'am, you, I didn't quite get your question.
On the survival.
You slowly explain and slowly tell that. Because on the survivor analysis, difference between the for the two
Death rates.
control and other
Yes,
two.
yes. So when they did the death rates per 100 patient years, so it was the death rate was more in the warfarin group. It was 1.9 per 100 patient years compared to the DOAC group, which was 1.8. But the p-value, it was not significant. P-value was 0.9.
My question was, when we look at the survival analysis graphs,
Yes.
around 30-60 days of treatment, there seems to be a marked dropout in the DOAC
Yes.
groups.
Yes.
But seems to be there in the warfarin groups. Only towards the end they meet together. So
Yes.
is there any commentary on this difference?
No. That not that I can recall.
And what are your thoughts on it? Is it that patients are dying early with dabigatran or any other DOACs, whereas they are dying later in patients on warfarin? And any ideas about that?
No, I would like to hear other people's ideas. I can't think of any possible explanation why late into warfarin treatment patients would have. I mean, all the patients that I have seen early period, the first 30
It would
days are
be
the
nice
most
if you can upload it. It's difficult.
Yes, sir. I'm not able to get my screen sharing. It's asking me to
Okay.
sign in into Zoom again.
Yeah, I think as we discuss other thing, if you
Yeah, I will sort that out.
quietly sit on it, I'm sure.
Yes.
Yeah. Others comments. Dr. Rajeshwari, your own impression you can give in the meanwhile.
Sir, I think it's probably maybe related to the numbers and the fact that they have tried the way they have put it up. Because in warfarin, I think there are over 500 patients, whereas in dabigatran, it's only about 280. So I think that it is the smaller numbers that makes this thing look apparent, but I would like to listen to other people's thoughts.
Dr. Goti.
Yeah, we are going through that. There is actually this study, that particular aspect, what you are telling, we didn't analyze that way. Because the reason is that right from beginning, my idea of this study is to sensitize and to plan for a RCT to solve this problem. So I thought that we'll study in depth later, but your point which you have raised, the numbers are so different, double in warfarin group, but these are all retrospective analysis. And there may be many more factors which has caused the death. So unless we have a prospective study to give importance to the death rates between the two groups, there are no two groups. The two groups were analyzed, made to look like an RCT. So I think that we should not discuss much about this retrospective aspect. I think Ilavarsi is going to talk about this.
Dr. Ila, your comments, please. Dr. Ila, are you there?
Yeah, she's there. She's going.
Yes, sir. Sir, I also think in the middle of the study, because of the patients who are lost to follow up, the study might have lost its power, and that is why this probable anomaly is happening.
Yeah, but only 15% only is lost to follow up, no?
19% are lost to follow, but the cause for death can be many. This is a chart review of the study. It is
Sir, the event rate is very low. With such a the event rate is very low, and with just 1.81 versus 1.9, it is very difficult to show any meaningful difference with these small sample sizes.
What she's saying, why they are coming nearer to each other towards the end. So that's what we know. Inference can be made in this study.
Sir, at the end of the study, there are only 158 patients in the warfarin group and 84 patients in the DOAC group. Almost 60-70% of the patients have dropped out. So it is very difficult to show any difference, even if there was any, at the end of 360 days, at the end of 1 year maybe.
That's true. I think that Rajesh should be satisfied with this answer.
This dropout in DOACs more significant, because even though they have managed to retain, there is a greater mortality in the initial days. So that's a cause for caution.
But more on the cost effect of DOACs in our practice day to day, we see people would not like to spend so much money. They are not happy. They would not like to buy. So I don't know what type of population, if it is free supply, people will take. If it is too costly, but we don't know real life scenario. I agree with you.
Yeah, but one note of optimism is that all these drugs, their costs will drastically drop down in another year or two. So we should be able to seriously, if they are really useful, I think sooner or later we will be embracing them, because the price difference, as you know, for many drugs after that initial few years, they drop down drastically, or there will be competitors.
So the problem comes in antidotes. No, antidotes they are giving free. It will not be available anymore free once we start using them freely. That will increase the cost.
That's it.
I think we should move on to the next.
I would like to ask something about the precision of the confidence intervals. Can you go to that slide?
Where the last confidence intervals is shown, no? Where you said all are not crossing 1. Yeah.
Why do you say they are not crossing 1?
0.47 is crossing.
No, all of them are actually crossing.
All of them are crossing. You said none of them are crossing.
All of them are crossing, and that's why p-values are not significant for any of them.
See, what happens is, no. If it is a risk difference, we use 0. If it is a risk ratio and relative risk, we use 1. This is a risk difference that is mentioned here, I think.
If it goes from -1 to +1, that means that it could be negative or positive. So isn't it 0?
No, Dr. Dulari, there is a null line of null value is different for risk difference, and it is different for risk ratio and relative risk. We didn't calculate risk ratio and relative risk because there are no groups here. It is only risk difference what you have done, and that is 0 is exactly the null value. That's what is the explanation.
No. You are talking about hazard ratios, okay?
But these are not based on any groups. There are no 2 groups here.
No, the hazard ratio is between 2 groups. That's
correct. They tried projecting it without any proper grouping here, because these are retrospectively all collected cases. They analyze retrospectively. There is a lot of bias that has creeped into this. So they tried doing it, but I don't think we should.
This is sort of hazard ratio, not really risk ratios. Yeah. Risk ratio is usually for prospectively conducted studies are the best.
That's correct. Where we use
risk. Yeah, it's kind of a hazard ratio.
Value is hypothesis generation. Null hypothesis will come into that. It's maybe hazard ratio is, yes, it's a type of how many people have suffered this, but based on what feedback we got, and these 2 groups which are used, it's only difference of risk, nothing else.
Hazard ratio is a form of risk ratio at any particular given time in the Kaplan-Meier.
But Eli, it is not possible in this. There are no 2 groups. They're not a priori. They didn't decide. They're all on charts looking at. They tried making it. They tried making it an RCT. Why we brought this trial is so that we now can plan a prospective RCT, so that more clear will be, because many people are using now without any evidence. That's why we brought this. So shall we, as a stroke society, shall we move a trial on this? And there are some plans to do that. So
in your adjusted model, what is the hazard ratio and confidence interval coming to? Can we show that?
I will go back to that.
Okay, so here major hemorrhages. I think you are telling with the model 2, correct?
Yes.
So yeah, here it is not crossing 1. They are on both sides after adjustment. In fact, for the model 1 also, isn't it? For both model 1 and 2. The confidence intervals are on the same side of 1. They're not crossing actually. Yeah. Wait a minute. So I think, yeah, from whatever, it's a clever way of showing that at least hemorrhages are significantly, and it does help to generate hypothesis, etc. But the major, I don't know, what's the kind of acceptability of dropout? Up to what dropout the study continues to maintain some sanctity?
What I am telling is true, Ilavarsi. Hazard ratio is the ratio of the hazard of an event in one group of observations divided by hazard of another event in a different group. So here it's the different group which they made. We cannot have a contingency table analysis in this situation. We tried doing that, but it's not possible. Comments, more comments, otherwise we'll move on.
So, Ila and Rajeshri, what's the kind of evidence this particular study is generating, in your opinions?
My opinions it will be more like a case series, because basically they have done retrospective, they have done cherry picked their databases, and then they have put together these numbers, and then they have not provided actually very easily understandable, like they have not provided the number of people who have died or the number of people who have actually developed a. So these are all important information that we will need, but they have not provided all of these. So I would put it level 3.
Level
no,
3.
No, the
strength of recommendation you are telling.
It doesn't look like a suppression. The way they just loss for follow-up is a real loss. That in real life, this can happen. To what extent they really try to track down these patients actively to see whether dead or alive. What efforts they made, those things would have been a little helpful. But otherwise,
they have done it from a country.
Yeah.
So they don't have control over these things at all. Whatever is entered in the registry is what they have presented. So it will be informative to us as readers to know exactly what numbers, because they usually use. So if we say out of 280, so many patient years of follow-up, so many people have died. That gives us some more information rather than just saying that 0.1, 0.9 and 0.8, 1.9 and 1.81. These are numbers around which.
Rajeshri, what they did was they followed a Cox regression model analysis. They calculated HR from there. It's not mentioned properly. I think it's a Cox regression model analysis. So it's only risk difference. That's why you're getting that 1.81 and 1.98. The risk difference is always studied with a 0 line. It's not with 1.
It is not risk difference. It is risk ratio only, sir.
Which one? HR, wrong. Yeah. HR is not. HR is event occurring.
Is hazard ratio.
Hazard ratio is one event against the other, not hazards in comparison with that. The correct definition is that HR का जो definition है, that is a ratio of the hazard of an event in one group of observations divided by another group. That is what is the ratio. So here they are saying
ratio will be a positive number only.
So 1.8, 1.9.
So the null.
If there is 1, there is no difference. If it is 2, the risk is double. The hazard ratio is double. That's how it is interpreted.
So unadjusted, if the hazard ratio confidence interval is including 1, then it is not significant only.
That way you are saying that way. But anyway, I mean, I only know this much that I can't. I think Dr. Prasad, if he's there, you would have
tried to do some justice with the existing data, looking at it. At the same end, of course, they have also expressed that these limitations do exist, and they are not blind to that. They are accepting that.
No, what Ila is saying, sir.
But my question is,
experimental rate and control event rate are studied. That's why she says that it should be 1. So, but it is not, it's not, it's crossing in the model. So I think we'll accept this.
I think in Western countries where they have got this record linkage and the patient data follow is not all that difficult. So I don't know why still such a why couldn't they have tried to see?
I think, sir, we are crossing the time now. I should move on to the next topic. Otherwise, we'll not be discussing like this.
Yeah. Yes.
Okay.
So anyway, interesting. I think it's certainly nothing against seriously looking at this in a prospective.
No, we should not look seriously about this analysis.
Yes, that studies are going on now, and so we will have to. Do any of you know any of the such studies are in progress in India?
No studies in progress in India as far as I know. And those two studies which he mentioned, they are in the clinicaltrials.com.
There was an attempt from the there was an attempt from AIMS to do a novel oral anticoagulants based interventional study, control study, but was it on cardioembolic strokes or was it in CVT, or there were attempts on both, but somehow it didn't cross the instruct trial priorities at that time. I remember this was in the agenda once. I don't know what
the instruct is concentrating on ischemic stroke. So far, they haven't touched ICH and CVST. So instruct is still they didn't come to the intervention.
Even in ischemic, there was a attempt to on cardioembolic strokes. There was a proposal from AIMS to try the novel oral anticoagulants. For some reason it hasn't crossed that approval. So maybe we should be. These patients do include a postpartum venous sinus thrombosis also, no? This is what I wanted to ask you. The percentage of peripartum CVT. What's the percentage peripartum CVT in this group?
They have included postpartum. I'll just show that.
Yeah, they have included, but what's the sort of percentage?
I think it's about 3%, sir.
Only that much. Oh.
3.
That is our problem,
and
not their
3.9. 3.2 and 3.9.
That is Indian problem, sir, not in these countries. Peripartum problem.
Yeah, so that would make a difference here, no? So its safety and various other aspects in the peripartum period is by and large.
We require to do more studies, sir. More studies, and RCT has to be done in large scale.
Say, just correct me if I'm wrong, but compared to warfarin, actually, the novel oral anticoagulants are not any less safe in the use in the peripartum period. Am I right?
Yes.
Well, there is no indication that nobody uses. It's only for non-valvular atrial fibrillation that is recommended. So we cannot really comment on this because it's not indicated.
No, it is standard recommendation for DVT and venous thromboembolism.
That way, not CVST, peripartum.
No. My question is tomorrow, if Dr. Koti, if you are planning to start one study, won't you be very keen to include a peripartum CVT also?
No, once we do ethical committee approval and we have insurance support, we can start a study. But it's a big question. Because we can't do a RCT without financial support and insurance policies. We can just start like that and include all cases.
No, sir. Will you include peripartum, like in the last trimester, in the just before delivery, someone develops a CVT? Will you include that lady in your RCT?
No, if at all I have to see the placental transfer of the medicine, whether how far it is safe and other aspects we have to check.
They're not any less safe than warfarin.
Yeah.
So from the
means they are non-inferior or both are equally hazardous?
If I'm right, then DOACs are not being tested in pregnant women. They are safe to use in the peripartum period. They are not transmitted in breast milk. So during pregnancy, even current recommendations suggest warfarin only. I mean, heparin only, sorry. Heparin.
So when we do that, then we'll have to
in
study
animal
a
data,
lot
they are
of
not
things.
more dangerous than warfarin. In fact, people say that they are probably safer than warfarin, but that's all animal data only.
These are all only assumptions.
No, sir, not just assumption.
No. Warfarin is clearly teratogenic in the first trimester. Embryo toxicity is very well known, and it is not recommended at least in the first trimester. Now talking about
syndrome is a fetal warfarin syndrome is a very well established entity.
Warfarin embryopathy is a known entity, and so in the first trimester at least, and in people who are potentially they can get pregnant, in such patients warfarin is best avoided. There is no question about that.
Only heparin can be given.
No, the question is, if some patient, for example, even if a patient comes with atrial fibrillation in term, would you recommend DOAC in such a patient?
In non-valvular atrial fibrillation.
Yeah.
Not the warfarin.
Pregnant. I'm not talking about warfarin. I'm talking about DOAC.
DOACs I never use. I don't use.
So in term, what will you give?
Heparin.
That is okay. So if you plan an RCT, would you include?
I will not include.
Why will you not include?
Because I don't know.
No, this is the problem. No, sir.
Because it's a hazardous to the lady and the son. How will I include?
No, if you plan to exclude peripartum females, it is impossible for you to reach any reasonable sample size. Impossible.
That is the question about 10 years back. Right now, peripartum by CVT is less. If you go to the analysis of any state, peripartum is very less nowadays.
Sir.
Used to be a big problem.
No, sir.
We are from Tamil Nadu.
No. You visit Nimhan's emergency.
Yeah, all of us will not agree with that, sir.
Nobody will agree.
But I think if you're doing an RCT on something, pregnant women, children, these are high risk and vulnerable population. So first you can always prove your safety in non-pregnant women. They have not taken pregnancy. They have taken 12 weeks postpartum. And this is not even an RCT.
The point is, if you exclude patients with pregnancy, at the end of the day, your study will never have any external validity. It will not be generalizable. And what is the whole point of doing such a study?
I feel with something which can affect the mother and child.
How do you know it will affect the mother?
I don't know. But first to establish the safety in non-pregnant population, and then you can go ahead and do it in a pregnant population. That's what I would think would be sensible.
We'll have to do many studies. It's not one study. Step by step, you have to reach that ultimate goal where you can generalizability is there. But it's not possible with the whole population.
They will not give ethical clearance for including pregnant women.
That's true. Nobody will give.
No. That is not true. That is a mental barrier that we ourselves build inside our heads. In
Gujarat, Anand is saying it is hyperhomocystinemia and males are more suffering.
Yeah, they do certainly occur in male, but I think the
trends are changing. Vegetarian diet.
Yes, sir, but things still continue to be a little more in favor of women.
So we can include them at a later stage, but we have to study safety.
Now I just completed a study, one of my DM students, CVT study. So it's still a major problem here, at least in this part of the world.
Yeah, safety and feasibility studies and the approval is very difficult, but you can try and subject your human subjects to harm if you want.
So anyway, we had quite an interesting discussion. It has brought to the forefront of discussion about this area. We need probably better drugs than the current oral anticoagulants in the treatment of CVT. Probably there are probably safer drugs. but we have to see which all groups of patients are going to be, we are going to be able to use them. And of course, all this comes after better evidence from good RCTs. But it's important that we do take part in this RCT actively. And I think because of difference in the kind of population between Indian and other population, like Vaishnav was telling about the hyperhomocysteine problem, and we in South Tamil Nadu, etc., and many other places, we continue to have CVT as the peripartum CVT as a problem even now. So all these factors took into consideration. We have to involve, and we have to probably lead the studies on CVT. We do have sufficient numbers. So I think time is probably right for us to, I don't know, all these European and Caucasian studies, what percentage of those patients were Asians, what's it from a multi-ethnic society, and even if they are Asians, how many of them are South Asians like Indians? All these are important. Otherwise, there will be DCGA and all are not going to give approval, even if these international studies on RCTs on CVT gets established. We might be, DCGA could ask for a trial in India. So I think we should be prepared to do that. And I'm sure that this discussion has been quite useful to think along those lines. I think now with the, shall we move on to the next two?
Yeah.
Which are eagerly waiting for.
Lot of,
so thank you, Dr. Dulari. Yeah. Did I pronounce correctly?
That's okay, sir.
Dulari. Yeah, Dr. Dulari. Thank you very much. It's a good exposition of how a paper should be read and how it should be criticized. Thank you for highlighting all its limitations also. And let us move on to the next program. Can you come out of this? Yes. So the who is going to talk next? Is it Dr.
Ila Vansi will be talking on biases in the retrospective study. That's the program.
Okay, we'll start. Okay, Ila, please. So the stage is set to give a talk on this subject.
We started the EBM segment from this week on, this month onwards.
Yeah, we decided that concern with that particular paper.
Is it visible?
Yeah, it's visible.
Yes, is part of it going out of the screen?
It has come, it's gone again.
For me, it was going a little outside the boundaries of my screen. Ila, it's no longer gone. It's gone now.
Okay, just a minute.
So as Ila is getting ready, I just want to convey to you, Dr. Gotia, I have finalized and cleaned up our member list. Yesterday,
I saw them. You added them into the group.
Yeah, I added them, but I will also send you the full list.
So sir, I would to invite all of them for our conference.
The Indian Academy digital team to help.
No, I did it by myself because what's happening is
Dr. Ila's presentation. I'm telling.
Is it visible?
Now it is visible.
Yes. Go ahead.
But I don't know. There is something in the top part. I'm not able to get rid of it. Okay, so we will have a semi-interactive session. So you can open your QR code scanner in your Paytm or any other app and you can scan this QR code, or you can use this URL and then use this class code. Then you will be able to interact.
Oh, okay. Yeah.
Okay. Just tell again. Now we use a phone pay or something.
Now, any QR code scanning app, Google Pay, Phone Pay, Paytm, anything.
Okay. Right. Something went wrong to scan again. Okay, scan again.
Well, this comes, I get a bit jittery because very often something happens to me and I don't succeed. Let me try this.
Yeah.
But nobody has joined. I don't know.
I think I have joined.
Is it?
It has come to me. I joined.
Yeah, one person has.
Two participants joined.
Okay, let us move. When we get to the question, we will do that.
Yeah.
Okay. So first of all, I would like to thank the Indian Academy of Neurology Stroke Subsection for giving me this opportunity. Today, we will have a short discussion on bias in retrospective studies. So we have spoken about this multiple times, and we can classify clinical studies as observational studies and experimental studies. So observational studies can be prospective or retrospective, but we should have this point clear in our mind that experimental studies are always prospective. You can never have a experimental study that is retrospective. So when we are talking about retrospective studies, we are talking only about observational studies. The observational studies, we obviously know that they are subject to innumerable number of biases, and the literature is actually the description of these biases, they have given some terminologies and various examples, but it is not as complicated as it is made to look. So let us try to simplify it and understand it. And before starting, we will just have a brief look at the various types of observational studies. Observational studies, basically, you can classify into a cross-sectional study in which at a single time point, data is collected about past exposures and the current status. But in a cohort study, you can have it in a prospective fashion in which you follow the patients or the subjects into time, or you can have a retrospective cohort study in which at a single time point you study whatever has happened to a group of patients with a similar exposure. And case control study is notorious for suffering from various sources of bias. And case control study can also be done in a prospective fashion or a retrospective fashion, and it can also be nested within a cohort study. So the topic was bias. Now my first slide is on validity. So you may be wondering why. We are interested in the distribution of parameters in the population, but it is difficult to measure because it is time consuming, effort consuming, and extremely expensive to study all the patients or all the subjects in the population. So we deal with samples. So what happens is you select a small group of patients who you think are representative of the population, and then you try to study the association. But the result of whatever you find based on the sample, it may or may not be truly representative of the population value. So validity is the extent to which the results of the study that you do in a sample is close to the truth. And what is the truth? The truth is the effect size of that particular intervention or that association in the population. And validity is broadly classified into internal validity and external validity. So internal validity, as the name suggests, is the extent to which the results of the study are applicable to the sample which has been studied. And external validity is the generalizability of that results to the entire population. So whenever there is bias in the study, that leads to threat to internal validity. And apart from bias, random error can also be a threat to internal validity. So broadly speaking, generally, whenever we speak of bias, we talk about selection bias and information bias. Confounding is considered to be a bias by some people, but confounding, let us keep that aside. We will limit our discussion to selection bias and information bias in today's discussion. So before going into bias, let us have a short look on what is random error. For example, if you want to study the distribution of weight in a class 10 students of the country, so what do? We cannot go to all the schools and capture all the students and measure their weight. So we try to do a sample. We try to measure the weight in a particular sample, and then try to extrapolate that to the distribution of weight in the amongst the entire population. So if on a particular day you just ask everybody to measure their weights and come, someone may measure their weight with their footwear on, someone may use their may measure it with barefoot, someone may use slippers. So if there is no standard operating protocol, each person is measuring the weight in a random way. So this leads to random error. Everybody is using a different weighing scale, everybody is using a different protocol, and this differences can lead to small variations, and that is called random error. So how can we get rid of this random error? By paying attention to detail and using standard operating protocols. So whenever there is a trained operator, usually he or she will measure the weight without shoes and using light garments. And the other method to reduce the random error is to increase the sample size. On the other hand, if on a particular winter day, you just go to a school and decide to measure the weight of a bunch of school students, they are wearing shoes and blazers. And that leads to a systematic inflation in the actual weight of the students by at least 2 kilograms. So if you look at this normal distribution, if this dark blue bell curve represents the truth, now this light blue curve is actually what is being measured in this particular sample. And if you look at it, it is systematically different from what the truth is. So this is an example for systematic error or bias. So when we talk about retrospective studies, most of the times it depends on previously collected data or on memory. So since there is no standard procedure followed to collect data in a similar fashion, it is susceptible to both random error and systematic error. So let us look at a few more examples to understand this. And before going on to examples, let us have a formal definition of bias. Bias is a systematic error. Now, the important word that has to be remembered is systematic error. Systematic error in the collection, analysis, interpretation, reporting of data. So what it means is, whenever there is a systematic deviation in any step of the study, that is going to lead to bias. It is different from random error, and it cannot be corrected by using a bigger sample size. So for example, if you try to test whether there is sufficient salt in a bowl of soup, if it is not stirred properly, and you take a sample of soup from the top of the vessel, even if you use a very big spoon, or even if you use a ladle, that is not going to be representative of the adequacy of the salt. That is not going to be representative of the actual soup, and so this testing is going to be biased. So this bias cannot be corrected by using a bigger sample size. So let us take this example. I wanted to study what is the distribution of sizes of fruits in this world. I cannot sample all the fruits of the world, and I'm not even sure where I can get all the fruits. So I did a quick internet search, and I found that if I have to try a wide range of fruits, I should try a fruit salad. It is cheaper than buying fruits from the market. Exotic fruits are costly and difficult to obtain. So I order a bowl of fruit salad from Swiggy and measure the size of the fruits with a measuring tape. And then I tabulate these results and send it for publication. Is there a problem? Definitely there is a problem.
Yes.
Yeah. So why has this problem occurred? This problem has occurred because of sampling. This is a selection bias. I have selected the wrong sample. Ideally, I should have gone to the market. I should have looked at various catalogs and catalogs of supermarkets and tried to order the fruits, whole fruits. Now, I made a mistake by thinking that if I order fruit salad, I will get a fair idea of how fruits look like. But this was an error. So let us see how we commit these errors in various study designs and how to avoid them, and when you read papers, how to critically appraise. So selection bias occurs when the sample studied is not representative of the population. It can be due to several reasons, one or more, and the literature is full of various complex terms. Most of them mean more or less the same. It is not necessary to remember the terms, but it is very important to understand the concept. So selection bias, as we have discussed just now, the sample is not representative of the population. Why is it not representative? It can be due to inappropriate definition of the eligible population. It could be due to lack of accuracy of the sampling frame. It could be due to application of uneven diagnostic procedures in the target population and loss to follow-up or non-response. Let us have examples of all these so that we will be able to understand it better. So before going, so I want to study the distribution of the weight of fishes in the ocean. So I buy a fishing net with a mesh size of 1 inch. And then I catch a bunch of fishes and then I weigh them by using a weighing scale. Now, is there selection bias? What happens to external validity and internal validity? So to answer this question, we should know, I wanted to study the distribution of fishes in the entire ocean. So many of the fishes may be of very small size, less than 1 inch also several fishes are there. So when I use this particular fishing net, I will never know never know the distribution of the weights of those fishes which are lesser than 1 inch in their size. So that leads to selection bias, and that will affect the external validity. But if I have my definition as fishes more than 1 inch, then internal validity might not be affected because of me using this particular fishing net. So as I told you before, there are several names of these biases, and lots of examples have also been given. So it may be difficult to remember these names and the exact definitions, but let us try to understand the concept. So selection bias, now we just discussed about whatever cases and controls that we select, they should be representative of the population. If the cases or the controls are not representative of the population, that is going to lead to selection bias. Now, when we are selecting cases and controls, both of them should be selected independent of the exposure status. For example, if I want to study the relationship between smoking and lung cancer, which is a famous and most often cited example whenever we talk about case control studies. Now, if I select controls with the inbuilt bias in my mind and try to exclude patients who are smokers in the controls, then that is going to lead to selection bias. Whenever I select controls, I should select them irrespective of their exposure status. So that is the most important point to avoid selection bias. Now, don't worry about these complicated names. We will just simplify them and see in the upcoming slides. Now, after selection bias, the next important type of bias is information bias. Here also multiple names have been given. Basically, what we are supposed to understand is information bias is because of misclassification of disease status or exposure status, and it can occur among both the cases as well as the controls. So this misclassification can be differential or non-differential. So what is meant by a differential misclassification? For example, if you ask patients who have already been diagnosed with lung cancer, whether they were smokers, they are more likely to think about what exposure they had. They may try to recall and they may try to question themselves again and again. And in that process, they may give a more thorough smoking history as compared to a person who has had who does not have have lung cancer right now, but who had smoked in the past, or who is a casual smoker, social smoker. So that person might not be giving such a thorough smoking history, and so this leads to a differential misclassification. One group is giving a better history, the other group is giving a poorer history. So that is called differential misclassification, and that can lead to association to be towards the null or away from the null. On the other hand, if you just go to a group of patients who had lung cancer, and you ask them something else, like for example, how much coffee or tea they used to consume. So in this situation, both the groups may be giving a reply that is not exactly representative of the true exposure, but this is happening similarly in both the groups. So this is called non-differential misclassification, and in such a situation, the association will be biased towards the null. So if you try to study the association between drinking coffee and lung cancer, if both of them give similar wrong answers or similar right answers, then there is not going to be any difference between the people who have lung cancer and who do not have lung cancer in terms of exposure to caffeine or coffee. And that is the results are always biased towards the null. Don't worry about these complicated names, we will see. So let us have this example, and based on this example we will discuss all these biases. So we planned a study in which we wanted to study the association of smoking with acute coronary syndrome. So what is the research question? We will break down the research question into our PECOTs. So what is P? Participants who had an acute coronary syndrome. What is exposure? Smoking cigarettes, BDs, or other forms of tobacco. Comparison group will be those without acute coronary syndrome, and we want to study the odds ratio in the setting of a CCU of a tertiary care hospital, and patients are assessed just before discharge, because when a patient just comes into the hospital with acute coronary syndrome, you are more bothered about giving the patient some form of intervention like thrombolysis or PCI. So you will not be having so much time to sit with the patient and ask before 20 years how much cigarettes they were smoking. So it was considered that just before discharge we will ask these questions to the patients. So what happens? What are the sources of bias in this particular study? So at each, as we saw previously, bias can occur at each stage of the study. When there is systematic difference from what is actually the truth, and that is going to lead to bias. Now, in this particular study, let us see at the level of participant what biases can creep in. Now, how do you define acute coronary syndrome? Especially in a busy tertiary care center. Now, in the emergency setting, nobody is going to take a textbook definition of acute coronary syndrome and classify it. Now, if you are planning a prospective study, that is a different story. But in a retrospective study, any patient who has been written as ACS in the file or in the registry or in the HIS, so those patients are going to be classified and taken into this study. Now, if that definition is not prospectively made in this particular retrospective study, there is going to be serious selection bias, because sometimes it is possible that a patient who had chest pain, but in this particular patient troponin could not be done because the machine was not working on that particular day, might also get classified as ACS. So it is not possible, it might not be possible to exactly define, because this is a retrospective study. But if the study is being done prospectively, that is a different matter. And there is also possibility of information bias in this setting, because the observer can also be biased. Now, when the patient comes into the emergency, the junior resident who is seeing the patient might ask history of smoking in a patient who has chest pain. And if the patient was a smoker, the patient is more likely to be classified as maybe having an ACS, may undergo ECG and other cardiac biomarkers. On the other hand, if the patient perhaps says that he or she is not a smoker, then the JR might as well think that this is just gastritis or some acid reflux, and may just send the patient away even without classifying the patient as ACS. The patient might not even be subjected to a ECG. So this is a huge source of bias. Now coming to the exposure. Now,
if I may, just one small thing. Can
Yes.
I say something? There is also a survivor bias, no, in this, because taking only patients at the time
yes,
of
ma'am.
discharge.
Yes, ma'am. I am coming to that. Yeah,
Sorry.
Yeah, this is this one, the time point. I'll talk about that. Hello.
Okay, sorry.
No issues, ma'am. No issues. So coming to exposure, when we are trying to assess the exposure, there is a lot of room for information bias, especially in definition. How do you define smoking? There are various forms of smoking: hookah smoking, chillum smoking, apart from the regular BDs and cigarettes. And it may be difficult to take history of all these. And there is a significant recall bias, especially in retrospective studies. There is a lot of room for recall bias. There is a similar bias which is called reporting bias. Now, when we talk about reporting bias, that is basically when a particular ECG is, for example, in this particular case, when an ECG is being interpreted. So some inexperienced doctor may if there is no standard protocol, may not interpret the ECG in a proper way. So that can also lead to bias. Now coming to interviewer bias, if the interviewer is already having some baseline idea that smoking might lead to acute coronary syndrome, then he or she may more thoroughly interview the patient who has recently developed a coronary syndrome as compared to the control. So these can be sources of bias when we are looking at exposure. And similarly, this workup bias and verification bias also occurs because a patient who has presented with acute coronary syndrome may undergo various other studies also. For example, if you really want to study the exposure of tobacco, you can do a urine test for cotinine, and then you can try and say that, okay, this person has been exposed to tobacco. But on the other hand, if you differentially apply this test workup, for example, if you don't do this particular test in the control group, then that is going to again lead to information bias. Now coming to the comparison, when comparison selection of the control group, that is the cause of major concern, especially in case control studies. Now, because this is happening in a CCU of this particular hospital, maybe I may find it very easy to select cases from the same ICU. I can think, okay, let me just select some patients who do not have an acute coronary syndrome, but in that CCU only some other patients are there who have been admitted with congestive heart failure. Now, this is going to lead to bias. Selection of patients from the hospital as controls leads to a lot of biases because patients who are in the hospital have a more likelihood of having that particular exposure or that particular comorbidity. So that may lead to bias in the association, and that bias is called Bergson's bias. The other thing is healthy worker effect. For example, if you go to the population and for example, if I want to select controls, maybe I try to go to a school and find age and sex matched teachers to have as comparison group. So healthy workers are more likely to not have various exposures. For example, a particular person who is working in an office or in a school is less likely to smoke or use IV drugs. So that can also lead to various biases because the healthy worker is actually different. The employed population is actually different from the overall population. Sometimes if I send out a survey form and ask people to come and participate, you may have volunteer bias. So that occurs because people who volunteer to participate in various studies, they are relatively more health conscious. On the other hand, if you send out a survey and find that 90% of the people have not responded, and that non-response is differential between the case group and the control group, that is also going to lead to a lot of bias. Now, the other problem is matching. When we do case control studies, we generally say age and gender matched controls. So that is because we think these are the most common confounding factors. On the other hand, if we try to match for too many other confounding factors, for example, you match for diabetes, you match for CKD, you match for hypertension. If you do overmatching, that is also going to lead to a very biased control group. And while selecting the comparison group also, this same information biases of observer bias and verification bias can occur, because the observer might be biased and might not actually classify this particular patient as not having ACS, for example. Coming to the setting in which the study is being done. So setting in this particular study, we were doing the study in a tertiary care setting. So what has happened? This is going to lead to two forms of selection bias. One is the spectrum bias and the healthcare access bias. Spectrum bias is happening because in a particular tertiary care center, you generally expect that the sickest of the patients are going to come in. So that is going to lead to a different spectrum of patients as compared to the actual patients who actually suffer, the total population of patients who are suffering from acute coronary syndrome. And healthcare access bias is another form of bias, because tertiary care centers are generally located in big cities, and people from the village might have difficulty in accessing healthcare in such a tertiary care center as compared to someone who is living close by within the same city. And the setting in which the study is done can also lead to information bias, because a particular patient, for example, comes to an institute. That patient might undergo a large number of tests as compared to a patient who is being treated in a primary health center. So that can also lead to workup bias. And verification bias is another form of bias in which the patient, for example, multiple people may be looking at the same patient in the tertiary care setting, while it may not be the case in a PHC. So that can lead to verification bias. Now, the most important thing, as Rajeshwari ma'am was pointing out, is the incidence prevalence bias, or it is called Neyman's bias. So what happens is, now in this particular study, we decided to look at the patients just before discharge. Now what happens is, if some patient has fulminant ACS, the patient probably dies on the way to the hospital or just a few hours after reaching the hospital. Now those patients are going to get systematically excluded from this study. Similarly, some patient who had a very mild problem, within 1 or 2 days may get discharged from the hospital, because we had to discharge that patient because we needed the bed for some other patient. So that is going to lead to mild patients and very severe patients getting lost just before discharge. Some patient may get discharged early, some patient may die early. So that is going to lead to a lot of bias in recruiting. This is also a major problem with retrospective studies, because in retrospective studies, already patients might have died by the time you just go into the community. So it is always a good idea to capture a particular time point and try and recruit all the patients who had presented. Rather than using incident data, it is always a good idea to use prevalent data to avoid this form of bias. So this we have already discussed. So let us have a look again. So when this Bergson's bias is otherwise called admission rate bias, and when there is a combination of exposure to a risk and occurrence of this disease, and it makes it more likely that such a patient is more likely to be admitted to the hospital, and such patients could have high risk exposures or diseases than the cases from the population. So for example, in this particular study, I decided to recruit cases with heart failure, or those who are admitted to the hospital in the nearby pulmonary medicine ward, or those with strokes or aortic dissection, all of them are more likely to be exposed to tobacco, and that may lead to bias because I'm using the wrong control population that is recruited from the hospital rather than from the population. Now, this also we have discussed. Healthy workers, most of the times people who are working in a school, in an office, are less likely to be alcoholic. They may not have so much time to binge drink or use IV drugs. They may not have much comorbidity status. People who have very brittle diabetes, they may actually quit work. So this leads to a significant bias. Now, this also we had discussed. Patients who have um, this this form of selection bias, in which certain groups of people get excluded either because of poor response to surveys, because of refusal of consent, because more volunteers try to participate in the study, or samples from the hospital-based studies in which is systematically different from the population. For example, patients may die before coming to the hospital. Different sets of patients reach the tertiary care. There is also referral bias. Even if the patient gets a referral slip, only those who are able to afford may ultimately reach a hospital like AIIMS. So various forms of bias creep in while selecting the sample of either the cases or the controls. So this also we have just discussed.
Ila, how many more slides do you have?
Am I audible?
Yeah, audible. How many slides more you have?
I think we have 4 more slides.
Okay.
So let us have this question. So you can respond. If patients with fulminant disease die before getting enrolled into the study, and those with mild disease, they get discharged before enrollment. And if it is possible that smokers with acute coronary syndrome die before reaching the hospital, and non-smokers are likely to stay longer in the hospital as they have health insurance and so they are able to pay. Now, what will happen to the association between the exposure and the disease? Will this lead to bias towards the null or away from the null? Nobody has joined.
No. Actually, what happened is this got disconnected.
Which one?
It's asking class code.
No, this is the class code 16911.
Because we did it, no? Then it's gone. No, again, we'll do it.
I think you are still connected, sir.
Now again, it's coming back, but it's asking class code. Now it has come. Yeah, it's come.
Your question you have to clarify once again. Considering the control exposure is calculated from the population data, will name and bias lead to
bias towards the null or away from the null?
Away from the null.
Who said away from the null? It is the correct answer. But why other people are not answering?
Because they didn't read about it. I only said, but I'm not getting your multiple choice here. Option A, option B. Option A is what? It's not
Towards the null.
Okay, option B is okay. Right.
So I think we have got 2 submissions. Both of them have answered away from the null. Yeah, very good. Okay, we'll go to the next one. So we were discussing about spectrum bias. Depending on the stringency of the criteria used, you may have a different spectrum of patients getting enrolled into the study. So for example, if I define stroke, acute stroke, as acute onset focal neurologic deficit versus an acute onset focal neurologic deficit with diffusion restricting lesion in a territory corresponding to that particular deficit, clinical deficit, which is a more sensitive definition, A or B? I think people have answered. Let us have a look. I will close the submission.
Yeah.
50. Okay, no problem. So the option A is a more sensitive definition, while option B is a more specific definition.
Specific definition.
Yeah. So if you just define acute onset focal neurologic deficit, some inexperienced physician who is in the emergency may mistake a patient who has maybe a post-ictal Todd's palsy, or if someone has a ophthalmoplegic migraine. So that patient may be misclassified as acute stroke. So, but it is, this definition is very sensitive but not specific. On the other hand, if I have a diffusion restricting lesion, for example, if the patient comes to, if the patient is seen by the neurologist senior resident, then the patient may have a more specific diagnosis. And so that leads to a spectrum bias depending on who is assessing the patient. Okay. So, so just to add to this spectrum bias, for example, if in a mechanical thrombectomy study, if someone uses only aspects more than 6 to select patients, this sample may not be representative of the stroke patients. It might not be having an external validity, but if you stringently follow this in that particular study, you will still have internal validity. That you have to remember. So coming to this next question, when there is loss to follow up, there is differential loss to follow between cases and controls. Who are the group of people who are likely to get lost to follow up? Those with severe illness, are they likely to get lost? Those with mild illness, controls, or all of them? So I'll close the submission. Okay. 2 people, majority of the people have replied as all of them. They are right. So people who have very severe illness, they may die, or they may decide to go to some other hospital. They may try to follow some other complementary and alternative medicine. So they may get lost to follow. Mild disease, they may not come because they got cured or they felt it was not significant. Controls are very likely to get lost to follow because they do not have any motivation to keep participating in the study and coming back to the hospital again and again. So all of them can get lost to follow. So this is the next question. As we discussed before, age and gender are commonly matched when we do case control studies. If we match for too many confounders, like overmatching, matching for factors that are not confounders, that will lead to what? Loss of association or false association? Okay, 3 people who have joined have answered. I'll close the submission now. 4 people have answered. Okay, the majority of the people feel that will lead to false association, but the answer is not false association. That will lead to loss of association. Basically, when we are matching, we are trying to match for the known confounding factors. Now, by mistake, if we match for factors that are not confounders, that will lead to overmatching. If there is overmatching, then the cases and controls may become very similar, and that will lead to loss of association. Even if there is a true association in the population, if you do overmatching, that will lead to loss of association, and it may appear as if there is absolutely no association between the exposure and the disease. So coming to this most important problem when we are dealing with retrospective studies. So people who have joined, can you tell me how many cups of coffee did you drink in the last month? If you remember, you write the exact number. If you don't remember, you can say you don't know. Can we remember? Okay, I'll close submission. Don't know one. Sir, you drank only 1 cup of coffee.
Yeah, I'm not a great fan of coffee.
Maybe it seems like you don't drink coffee. Someone invited you and forced you to drink. That is why I remember.
The only one was in such a situation.
Yeah. Okay.
So Dr. Goti is also, he also doesn't drink.
Yeah, he also said he doesn't remember. Okay. So it is very difficult for people to remember what had happened. That is why we should always try and use health records like that was done in this particular study that we discussed today, or we can use biomarkers, or some better way rather than just asking some random question like how many coffee you drank, how many tea you drank. That is not a good question at all. And other forms of information bias, we had discussed this, like observer bias and interviewer bias. This we have discussed if we try and use the exposure in actually making the diagnosis. This is called circular reasoning, and it is very common in diagnostic studies, especially when we try to do diagnostic studies in a retrospective fashion. It is there is a lot of scope for having this observer bias. And this interviewer bias and reporting bias also we have discussed previously in detail. So, and coming to the last form of bias, especially in retrospective studies, sometimes this temporal ambiguity can occur when the exposure, it is very difficult to establish whether the exposure preceded the effect or after. And it is very common in cross-sectional studies, in ecological studies. So for example, this we are we very much see this every day in our practice. So when you ask patients whether they take alternative medicine, for example, in a patient who presents with peripheral neuropathy, it is very difficult for patients with very long duration of illness to remember whether they actually started this medicine after they started having neuropathic symptoms, or these drugs were the real cause for this neuropathy. So in long-standing illnesses and patients who have been recruited long after the diagnosis, this problem leads to a lot of bias, and especially when there is lack of reliable records, biomarkers, or poor recall. So these are the various types of biases that can creep in and lead to false associations or loss of associations that truly exist.
So are you finishing here? Or?
Yes, sir.
So yeah, I have a question. This is a real issue. I won't I'll make it short. See, if you read any study, you can. It's not very difficult if you are sufficiently reasonable to find out many biases between the comparing groups. So I think we, instead of, many a time I feel that if you go on a bias hunting mode, it's probably far too easy. So where do we decide? But at the same time, we have to do studies, and we have to make sure that whatever we are important in analyzing, those parameters are touched least by the potential biases in our various levels. So I think the teaching probably has to spend more time on some general methods to avoid all kind of major biases, and let some minor biases be there. And of course, what is minor and major may shift from what we are analyzing, which parameters we are analyzing. But I think some general important principles to avoid all major biases is what would be very important for young researchers who start the research, because otherwise they could be completely pissed off and they may get too frightened to start any research at all.
Is that a question or a statement, sir?
No, I'm making a statement actually.
The important thing is that the bias can be controlled only by good research technique. No statistical test can correct the bias. Whether random error can be adjusted by statistical methods. So it's important for us to adopt a good and scientific method to do a way of avoiding biases in prospective studies. I think, Sunil, shall we stop here for today, or you want to continue? It's already 8:45. We have exceeded.
Yeah, I mean, I was wondering what to.
People have already left.
Yeah, that's what. We will start on a fresh day. With.
I don't mind. I don't mind. I mean, postponing my talk to the later part, because we have already exceeded our time limit.
Yeah, if you don't mind, because
no, I don't mind.
University has told me so many bias. I'm just trying to recall how many of them I remember.
She has done very, very well. But next time onwards, we'll restrict to the topic which is given and research methodology and EBM to that particular part only. We'll not go on to the overall subject matter of whenever we do.
Always when you give a talk like this, you conclude by generalizing a few 2-3 slides on how to circumvent most of these biases and which are the major steps we can take. Many of the steps can actually, a single step can actually remove it's kind of a what you call this multiple types of biases can be removed by many of the single interventions.
No, there is no limit to learning. What I mean to say is there is so much to learn and talk and do, but we'll restrict ourselves to what is given in the article and what is relevant to the article next time onwards, so that we stick to our time frame. Okay. And in discussions also, we have restricted time. We should finish by time. Otherwise, it'll go on and on. I think with this,
what could have been done in that particular study with similar techniques to
the name and bias is the most important in that study that has bothered that study very much, and there are a few others which you can highlight. So this is an important study for us to, I think, design a study, a hypothesis generation study, and we will do that. We'll do that at RCT, but we cannot recruit pregnant ladies at this juncture. It will be at later step, and the perpurium and these things will have later. But we are seeing more in cases who are not there. We are seeing more number of men.
Lot of registry data in which patients with AF, patients with especially venous thromboembolism during the peripartum period, there is data in pregnant females who have received DOACs.
Actually, there's a new trend in the Europe now. They are trying to see with the help of very powerful multiple databases, trying to see using large data analysis, which is your favorite field also, Dr. Goti, artificial intelligence. Try to get the information that we can gather by very long, costly prospective intervention trial. Could we get some very good information close to what can be derived from RCT, maybe not to that level, by intensively and studying deeply the registry databases, where if you have patients who had got exposed to direct anticoagulants or warfarin, or those who had been received only heparin, or those who never, if you are able to collect all this data from registries where these are automatically being maintained, this data collection is being automatically happening, like say maybe Framingham and so many other places where there is multiple record linkage systems. then we could get actually good information.
So this GWTG get with the guidelines stroke registry.
Yes,
and various there are DVT, this
wherever there is deviation, that deviation can be used as the other arm of the study.
And so, patients who get accidentally, who get pregnant and they do not know, all the data is currently available.
Yes. So I think work should be done on such database.
Yeah, we'll definitely take
analytical tools.
and look at all those things. Because if you ask whether if you are next of your kith and kin, you want to give this medicine or not, you'll get the answer, whether you want to do the trial or not. If you want to do to your own sister who is pregnant and give DOACs without any evidence, do you do?
Yes, if there is clinical equipoise, it should not be done out of a clinical trial. Within a clinical trial, definitely we should try and recruit as.
So for that, we require a lot of money to support the insurance. That's the whole problem is that all our cities require a lot of money.
Yes.
Every case has to be looked after till the follow-up, and whatever happens to the patient, you have to bear the cost.
Not only the patient, to the fetus and the newborn.
Yes, yes, that's a huge cost. That's why I'm afraid of doing it. It's okay, nobody will clear that. Anyway, sir, I think we'll take leave. It's already 9 o'clock now, and next time we'll do confidence intervals.
Yeah,
you,
so I think we had very interesting fruitful
lecture. Dulari has presented very well. Yes, very elegantly. She brought out all the points in the study, and Ila has done a wonderful job of biases. She taught us many things. The next time we will have confidence intervals in next. But next month we will not have this journal club because of our midterm conference. We'll again
let me, Dr. Ila, you please pass on our conference notifications to all your students in AIMS, not only the DMs, but also those who are doing MD and interested in stroke and neurology, and even those people who are in the basic sciences. Please spread a word and try to, can you take some A3 printouts and put it up in some strategic places? I will ask Dr. Padma also. Dr. Ila?
Yes, sir, I will communicate to our residents. Some of them are attending also. I think they have just left. I will tell them.
Right, okay. So, and also your neighboring places also through word of mouth, you please inform them. I think it's going to be an interesting program. Are you coming in person?
You are asking me, sir?
Yeah.
I don't know, sir. It is very difficult to say. That is actually just the end of vacations, no? 15th our vacations end. So I'm not sure whether we will be able to.
Okay. Yeah, but try to join if you are.
Online, definitely we can join.
Yeah, online, of course. Yeah. We want you to actually involve with Dr. Rajeshwari and our team to, we'll give you some specific roles also on those days also.
What role?
Whatever role you want to do.
I operate from here, remote control.
Yeah, that's okay. No, you can do remotely also a lot of things. But join in, you take a slight off in the last 1 week from Annals of Indian Academy of Neurology. And
sir, what is the relation between Annals of Indian Academy of Neurology and this, sir?
Time. You want some of your time. Yes. You are an alumnus of Neurology Department.
Hello.
Join us. Okay. I've been keeping posting that already, so I don't want to again show it up. But the latest brochures correctly give the registration details online. We'll get it as a Google Documents registration, and also the payment portals, and also the abstract submission. So please do encourage. Hello. Please encourage students to submit abstracts also.
Okay, that's good.
Okay.
Okay.
Right then, and if you have any feedback on the brochures, anything you think to be corrected or modified, please feel free to let me know.
Okay. Right then.
Thank you.
Okay then.
Thank you
Good
very
night.
much.
Okay,
Bye
good
then.
night.
Good night.
Good night,
Thank you.
everybody.
Bye.